Good afternoon, everybody. Since the morning, everyone has been thanking me, but I would like to thank all of you, our esteemed faculty who have been giving excellent talks throughout the day, and the very keen audience who has been gracious enough to come to this CME. And I hope you all are having a good input of knowledge with this. So I shall be mainly, we have spoken a lot about postoperative endophthalmitis and just had an extremely enriching talk on traumatic endophthalmitis by Dr. Naresh. I shall be looking beyond all this, and my talk basically focuses on endogenous endophthalmitis, which is endophthalmitis that occurs in existing systemic or local organ infection. And there is a potential for it to spread hematologically to the other tissues. And it accounts for about 2 to 6% of cases of endophthalmitis that we see. This diagram with this image, which is a part of the stock image of Microsoft PowerPoint, has been used extensively today by all of us. So the causative organism in the developed world, that endogenous endophthalmitis is more often seen due to fungal organisms are isolated, but in Asian countries, the bacterial organisms are more common, fungal and counting for only 17%. Also in the bacterial, in international developed world, you see more of gram-positive isolates, but we do tend to see in the Asian countries more of gram-negative isolates. The sources of infection can be from any infectious source anywhere in the body, pneumonia, endocarditis, liver abscess, renal abscess, psoas abscess, candidemia. It can also occur very often in our patients who are poorly controlled diabetics from the carbuncles that they can develop, or even from the diabetic foot they have. Even that can be a source of infection, which is quite common. The organisms isolated gram-negative, again, we see Klebsiella, and in gram-positive, it could be Streptococcus or Candida. As we just spoke, Candida is more common in endogenous endophthalmitis. In India, just Streptococcus pneumoniae, Pseudomonas, and Candida are most often seen. The risk factors is basically anything that lowers the immunity of the person, which could be any chronic immune compromising disease like poorly controlled diabetes, patients in chronic renal failure. They may also be undergoing dialysis. They may have indwelling catheters or an AV fistula created for that. Seropositive immunocompromising diseases, immunocompression due to chemotherapy, and also IV drug abusers or patients with severe burns. This occurs due to the metastatic spread of the organism from a primary infection site, and the spread is more often hematogenous than a direct spread that is from perioculars or CNS tissues. And it's reported in literature that right eye is more commonly involved, or more commonly involved first, possibly because the right carotid artery is more vertical in orientation, and so the organism or the septic embolus travels directly through there. So if you look at how it would occur, so there's a septic embolus formation in the organism in the bloodstream. This embolus then enters the eye through the posterior segment vasculature. It disseminates through the ocular tissues, spreading to the surrounding ocular tissues. The ocular barrier is breached. The organism proliferates in the eye tissue, and this incites an inflammatory reaction, which is responsible for the damage occurring to the ocular tissues. This was a case that we had seen long ago. This was a premature baby who was initially seen by us for ROP screening and was called for a review, but reported about a week later had some zone to immature retina. The baby reported back earlier to us with the mother complaining of the one eye having gone red and having discharge and looking whitish. And when we saw the child had developed endophthalmitis in one eye, and when we took the baby into the OT, we also noticed there was this large necrotic tissues. It's called an eschar, which was there on the hand. So basically, the child had extravasation of IV fluids during its time in the NICU, and that had led to this necrotic skin formation, which this thing came off, and we took culture from this site, and we also took a culture from the eye, and both give the same organism, Serratia. Though the scar on the eye hand healed, the eye went into phthisis eventually. It's very difficult to manage endophthalmitis in such small eyes. So this was one place where you can localize, and we had a culture in both the places of the same organism. Clinical features is essentially like that of any other endophthalmitis. A few remarkable points here is that a bilateral involvement is more common, though the bilateral involvement may not be simultaneous, it may be sequential. The vitreous or the posterior segment involvement can be in the form of a retinal or a chorioretinal abscess. and the exudates tend to be more significant or denser, and they are more prone to go into panophthalmitis also. So certain signs have been suggested to be indicative of endogenous endophthalmitis in literature. So abscess of the choroid, more hypopure, more vitreous exudates. You can sometimes see the septic emboli. You can have necrotizing retinitis and perivascular hemorrhages and infiltrates, which can be seen around the vessels. So here, let us look at this patient who presented to us. This was an uncontrolled diabetic, was not taking his medications regularly, presented with drop of vision in one eye. This patient had a macular subretinal abscess, and you can see there were a lot of hemorrhages also around. The diabetic control was poor. He was treated with intravitreal and systemic antibiotics and was referred to a multi-specialty hospital for systemic control. Over a course of systemic control with systemic antibiotics and a couple of intravitreal injections, the lesion healed well and eventually led to a scar, which was in the macular area, and hence the visual recovery was poor. No organism was isolated here. So some special features you can have is bacterial infections can have subretinal or choroidal abscess. Candida presents with those fluffy white lesions which extend into the vitreous cavity. Aspergillus can have yellow or white lesions, and there can be associated retinal hemorrhages of cotton wool spots. MRSA infections can have a higher rate of retinal detachment, and Mycobacterium tuberculosis, which is very rarely causes endogenous endophthalmitis, can be associated with scleral inflammation. So these are images of how the Candida endophthalmitis looks like, and I think we have also seen some examples in the cases presented today. This point was already discussed, that diagnosis is a challenge because there are two issues: that in a patient who is sick and especially admitted in the ICU, the systemic status and struggle for life takes precedence over the ocular. And in a patient who may not be very awake or oriented, also the ocular signs may be missed until they are advanced, leading to a delay in diagnosis. And poor microbiological yield, I think this was already discussed. So if you take a deeper biopsy from the deeper tissues, you get a better microbiological yield. Timely diagnosis, a multi-specialty treatment for faster improvement, a constant vigilance to look for other sites of infection, and a good systemic control are paramount in achieving a good outcome in these patients. So like I still remember, we had a patient who came to us once. He was a poorly controlled diabetic with very uncontrolled sugar, had some diabetic foot and all, presented with drop of vision in one eye, obvious endophthalmitis, couldn't be taken up for vitrectomy because sugars were poor, but somehow we convinced our physician and we went ahead with an intravitreal injection. And at that presentation, the other eye was normal. The next day, the very next day, by the afternoon, evening, we have seen and treated, given injection there. The very next day, the other eye showed the appearance of exudates in it. And the patient's sugars were still poorly controlled and was showing deterioration. So we referred the patient. Our favorite place is Jipmer. Amit gets the load from us always of these patients because we do not have a systemic management backup here. And I think not only did the person worsen, but unfortunately, this person also passed away 3 or 4 days down the line. So just a warning that be very vigilant when you see endogenous endophthalmitis patients. They may be systemically really poor and actually not only losing their eyesight, but may also be at a high risk for mortality. Ultrasound B scan, we've already looked at it, can help us diagnose the underlying condition. So the first treatment here is you have to manage the underlying systemic condition. It is good to have urine and blood culture samples, and these should be collected before starting the antibiotics. So that is important. Otherwise, the sisters will immediately give the antibiotic, but will forget these. And the rest of the treatment proceeds as we have been discussing since morning, and optimize the medications according to culture sensitivity. The management of endophthalmitis proceeds. And so here is a very interesting experience we had. So we had a 43-year-old poorly controlled male diabetic, a radiographer who presented to us with diminution of vision in the right eye and a vague history of fever a few days ago. He had an anterior segment reaction, a drop in vision in the anterior segment, but left eye, anterior segment and vision were normal. At presentation, he had this large retinal, subretinal abscess in the right eye with vitreous haze, but the left eye also showed sclerosed vessels and a locus of infection. He was initiated on topical antibiotics, and because of his prior fever, he had already undergone, and working as a radiologist in another hospital, he had already undergone a battery of tests. So we called him back the next day to come back with all of those reports. So when he came back, his culture, urine culture was positive for E. coli. He had an increased neutrophil count, but there was no signs of leukemia or anything. his sugars were poorly controlled. The E. coli had high sensitivity to amikacin, so his topicals were changed accordingly. And a diagnosis of endogenous endophthalmitis with retinal abscess was made. He needed blood sugar control, so he preferred to go back to his hospital. Actually, though the blood sugar values may not appear very deranged here, he was very sick at that time, and we could actually make that out that he was not in a good state. So he went back to the multi-specialty hospital where he worked. His topical medications were continued. During his course, from the time we saw this till he came back to us 12 days later in the multi-specialty hospital, he developed acute respiratory distress syndrome. He was intubated, ventilated, blood sugars were controlled. He developed multiple abscesses in iliac, psoas, and gluteal muscles. He had left lung septic emboli. He had left kidney pyelonephritis. He also had some infection at the IV line site. And while going through all of this, and a battery of various antibiotics were administered to him there, he also received 2 intravitreal antibiotic injections in the right eye by our colleagues in that hospital, who coordinated with us and kept us in touch about this case every day, and we remotely guided them to managing this patient. Left eye was not injected because it was the better seeing eye and patient was reluctant. And also, whenever he was little stable and they moved him to the OT to give the right eye intravitreal, and then he would become unstable and something else would develop. So the left eye was never injected. Eventually, he came back to us 12 days later, and now he had developed a break at the site where the abscess was initially, and had a total detachment in the right eye. The left eye also had a break at the site of the original abscess, and he had a partial retinal detachment. So he underwent bilateral retinal detachment surgery, the right eye immediately, and 4 days later, I operated the left eye. By this time, he was systemically well. He remained and maintained good control. Retina attached well, but he somehow developed early emulsification, I presume, because it was an eye which had a locus of infection at time of surgery. So we did a SOR with the cataract surgery 2 months later for the posterior subcapsular cataract he developed. Both the areas were well scarred, and he went on to develop a visual acuity of 6/9. So what this case emphasizes is that timely management can help you gain good visual acuity, and team effort is what can bring about success, whether it is in managing endogenous endoph, or thanks to my colleagues for helping me with all the things I needed for this presentation. Thank you.